Welcome everyone. We will be getting started in just a minute as soon as we give a chance for everyone that we're in the waiting room to be added in, which should be just a minute. Okay, well, welcome. I will introduce myself and the panel moderator, and then I'll turn it over to them. Welcome to our fifth and final session today for the third annual Hacking Human Conference. I'm Dr. Rick Hall. I'm a clinical professor in the College of Nursing and Health Innovation at Arizona State University. And I'm also the founder of the Health Entrepreneur Accelerator Lab. And one thing that the Health Entrepreneur Accelerator Lab does every year are put on events and workshops and conferences such as the one that you're in today. This is, like I said, our final session for today. We will wrap it up by 2 o'clock. It's actually a little bit earlier than that. It's at 1:30, as our slide says. Thank you for being here. At the very end of this session, we're going to give door prizes away. So we hope that you stay till the very end, and 3 lucky winners of our participants will get a door prize. In addition to thanking the panelists for being here today, I want to also thank our sponsors. We have Audacious Studios, Nutritional Brands, and the City of Phoenix, who have continued to sponsor. And I also want to thank our HEALab Advisory Board, who are regular contributors to the HEALab activities, which help our students, faculty, staff, and community members come up and ideate and with real solutions to real health problems. And then our hope is that we can help them accelerate their launch to commercialization with these healthcare solutions. So without further ado, I'm gonna turn it over to Ramona, who is a past Health Innovation, Master's Health Innovation student, currently a faculty member in the College of Nursing and Health Innovation, and also a moderator for today's final session on tools and solutions for managing connection. Oh, and one more thing, and Taylor just put it in the chat, please feel free to ask questions throughout the conversation today. So just put them into the chat and we'll get to them toward the end, and we'll try to get to as many questions as we can, but don't hesitate to ask questions as you think of them. Okay, Ramona, it's all yours.
All right, great. Thank you so much for having me here today, for pulling all of us together. It's I've been actually able to attend many of the sessions this morning, so I feel like I've been on a journey actually today on this Friday of another kind of big intense week in this heavy year. So great topic for and timely topic, appropriate topic for the year. And so I want to just take a minute to kind of set the stage on what we're talking about in this session and what we've been talking about all day today, really. We started out our day really talking about the issues that we've been facing this year. Unexpectedly, again, when this conference was being formed, topics of burnout, isolation, and health disparities, and shifting into topics around resilience and mindfulness, and using our tools for supporting us around our own well-being. And now we come to a point in our conversation where we will bring it home by sharing with you all tools that help us to manage connection. And so I have 3 amazing panelists here. Cindy Jordan is here, James Bates is here, and Walter Greenleaf. And I'm going to have them introduce themselves in a minute, and I'm going to have them introduce themselves in a slightly different way. I'm going to have them talk a little bit about their ventures and how they approach this topic of tools that help us with connection. But I also want to ask them as they introduce themselves to share with us what they're seeing as well in this year of so much change and so much new that's coming at us around this topic. I want to also ask them to spend a little bit of time not only talking about their work and what they're doing, but also talk about trends that they're seeing. And so I want to go to you first, Walter, to introduce yourself to our audience and tell us a little bit about your work and those trends that you're seeing.
Well, sure, and thank you very much for inviting me to be part of this presentation. It's wonderful to be with you. It's an exciting time for me personally, and I'll describe why that is. I mean, it's a challenging time for all of us, and I always feel a little bit embarrassed to say that it's an invigorating time for me because I know there's so much turmoil out there in the world. However, for my field has really had a large surge forward over the last 6 or 7 months. And it's capping on top of a big surge forward that was already in process. What I do, I'm a research scientist at Stanford University. I'm a behavioral neuroscientist, but I'm also a technologist. And I started working in the field of digital health and also virtual reality and augmented reality technology back in the late 1980s. And so for me to see the rapid acceleration that's been going on and the acceptance of new digital health technologies into the healthcare arena has been really exciting. And in particular, because I work in virtual reality technology, to see that there is now affordable and comfortable, very powerful VR systems that can connect us, that can be served as a platform for digital health is very exciting. So I'll pause, but let me just describe very briefly what I'm doing outside of the university. I'm working to connect some of the academic groups, the early stage startups, the medical device companies, the pharmaceutical companies, and the healthcare networks to leverage this momentum, all the hard work that's been done in the academic centers, and get it out as products. And there's been a big surge forward. It's an exciting time.
Absolutely agree with you. It is an exciting time and also resonate with your comment, Walter, that it is hard to say that it's an exciting time when there is so much trauma in the world, but there is so much innovation happening right now. I want to now go to you, James, to introduce yourself and tell us a little bit about what you're working on and the trends that you're seeing.
Sure. My name is James Bates. I am the founder and CEO of AdviNow Medical. And what we have noticed is really happened long before COVID, but the patient-doctor relationship and the relationship between patients and healthcare overall has been in a steady decline for many, many years. The clinics have been under tremendous stress on the amount of information they need to collect such that they actually get paid by the insurance companies. And what it ends up meaning, even before COVID, is that doctors are spending 2/3 of their time on documenting medical information about the visit in order to get paid rather than spending that time with patients. So what AdviNow Medical has done is we use artificial intelligence and augmented reality to actually create a system that will collect the information for the doctor to return that time back to the doctor to spend with patients. So that's why we were created 4 years ago, long before COVID. What we noticed with COVID is that it's actually created a much worse situation than was already there. Doctors from all over, all different types of specialties are now using telemedicine for the first time. And what I hear is that they spend more than 50% of their time debugging the Zoom call, right? How do we get it going with the patient? Well, the beauty of a system like AdviNow, and not to be too, advertising about my company, but really what's required for the future is that it's all a turnkey solution. How the patient sees the doctor is less important than the patient actually sees the doctor, whether that's in person or whether that's over telemedicine, or even if it's just text messaging back and forth. It needs to be smooth and seamless and easy to use, such that the time that's left is not about asking questions and writing information, but about talking with the patient about what the treatment plan is for them, is best for them.
Love what you're saying there, James. And we're going to poke at that a little bit more as we get further into the session today. So look forward to that, everyone. Cindy, I'd love to hear you talk a little bit about what you're working on and some of the trends that you're seeing.
Thank you. So I'm Cindy Jordan. I'm the CEO and co-founder of Pix Health. Pix Health is a mobile technology solution that solves for loneliness and social isolation. And I'll talk about that in a second. But I got here because actually this is my second healthcare IT startup. I sold my first one to the advisory board, gosh, about 7 years ago now. And if you had asked me at that time if I'd ever do another company, the answer was unequivocally no. But I changed my mind when I had this year in between my last company and starting Pix, where my stepdaughter, who's diagnosed and suffers with bipolar, had a terrible decline. So in a matter of 12 months, she went from very, very stable, good life in school to being in an inpatient facility. And there was addiction and all kinds of crazy things that were thrown in there that come along with behavioral health. And when we got through it as a family, and I kind of took a look at it to see what did we miss? Like what happened along the way that we just couldn't, get our arms around. And the very first thing that she did was to socially isolate, and even from her family. So I did a ton of research. What is healthcare doing around social isolation and loneliness? The UK is way ahead in this department, but not the United States. And sure enough, the answer was basically nothing. So that's how Pix was born. And Pix is this combination of really smart, but super funny, lots of humor, empathy, compassion is our artificial intelligence. It's Pixar. He's behind me right there. So we use him in the technology solution to keep people connected and provide them some companionship. But when their needs get to the point where they have to have human connection, or they maybe need some social determinants of health intervention, we also have a whole call center that that intervenes. So I like to call Pix kind of like the peanut butter and chocolate solution. It's the perfect combination between a scalable technology solution and human intervention, which is what you need if you're going to tackle the loneliness and isolation problem.
It's fantastic. And we're going to talk so much more about that. There's so much to say there and unpack. We could do a whole session just on loneliness and isolation. So I want to talk first a little bit about provider and patient interactions, and we're going to be talking about all kinds of connections today, but provider and patient, and let's talk to you first, James, about this. It's the focus of your work, and provider-patient interactions have changed. You noted that the telehealth has just taken off. It's not new technology, but suddenly we're all doing it. And I know you think about this a lot. So I'd love to hear you talk about how COVID has altered our interaction with providers, positive or negative, and what you see changing as we move into the future.
It all starts with how clinics used to operate and how they must operate today in the new reality of social distancing. And, if you go back a really long time before electronic medical records, doctors actually didn't take very detailed notes of a medical visit. They would scribble a thing. There's lots of jokes about how terrible doctors' handwriting is, because they actually had that patient-doctor interaction in the room, and then they would scribble a few things down for them to remember. But if they understood what they wrote, that's good enough. When electronic medical records came out, it forced them to be spending a lot of time writing it down, because that became something searchable for lawyers. And ultimately, getting that accuracy really started to hurt the patient-doctor relationship. So now when COVID came, now you had a situation where they had a system. The front desk would collect a certain type of information. Then it would go to a medical assistant that would collect certain type of information. Then it would go to the doctor to collect, certain types of information. And now this is all done by Zoom. And many times the doctors are now responsible to collect all that information. So now the patient visit, which used to be even truncated where the doctor's just asking their piece, the doctor's now spending a lot of time checking payments, asking about their patient history, stuff that maybe the front desk used to do, as well as whatever reason they're coming in, their chief complaint. And so what doctors have noticed is that it's become unbearable. So that is the first thing. The data collection aspect of telehealth, it really just tears apart the provider-patient relationship more than it has been. But now as you go forward and you start thinking about, is this sustainable? Well, then you have to look at how much they get paid. And what happened with COVID is, yes, people get paid for telehealth where they didn't get paid for before. So that's a good thing. But the amount that they get paid is actually a lot less than it used to be. So now a provider is spending more time with the patient, collecting more information than they used to get, and they get paid maybe 50% to 80% of what they used to get paid. So all of a sudden, a lot of more increased pressures are coming on the clinic, and that hurts the patient-doctor interaction even more because now they're rushing through things to be able to at least maintain the semblance of a business. So COVID is broken the system. So if everyone thinks it's temporary, then they think that, okay, we'll just power through it. But after 8 months, it's not very temporary. And quite frankly, as we're looking forward to when some type of normalcy will be everywhere, we got another 6 months to go before everyone's vaccinated. So this and who knows when the next COVID-like illness is going to sweep the earth. The systems need to be regenerated, and that's where technology comes into play. So what I see going forward is that you end up with technology companies, similarly what Cindy said, where some type of technology, artificial intelligence, is going to be engaging with the patient until they have to pass it to the doctor. And this is what I see being the standard of care going forward.
I want to just add some thoughts to that. I love everything that you're saying, and want to mention one of the, it would take a while to share all of the aspects of my background beyond being a former student at ASU and now working as a member of faculty, but I'll quickly share that I also have a nursing background and spent a lot of time doing community health work, and home care is a place where I spent quite a bit of my time. And I've noted that with telehealth and virtual care, providers now have an opportunity that they did not have before, that I had as a home care nurse, to see what's going on in the patient's environment. So I'd love to just add that element to your thinking and ask you to react to that, and maybe we can add that to our conversation as we go forward today, because I think it's an interesting dimension to what's happening around how we deliver care at this time.
I completely agree, Ramona. When you start looking at care, what some of the estimates are is 30 to 50% of the cost of healthcare actually comes down to social determinants. And once the provider gets a view of what's going on in the house, there is tremendous value that can come from that. So I agree 100%.
Yeah, it's fantastic. So anything that you'd want to add to that, Walter, in terms of things that you're thinking about in terms
Sure.
of AR, VR,
Well,
how that might play in?
I guess I'll tell a story, and I'll point us to a particular important use case. I'm very concerned about our aging population. We often hear talk about the second pandemic being that of mental health, stress, and wellness because of all the anxiety, depression people have had, and there'll be a certain amount of anxiety as we return to work, as we return to school, relearning, dealing with apprehensions about getting close to people, etc. That is an immediate concern, but further downstream is a issue that's been looming now for a while. All we have to do is do the math. and that's the crisis of senior care. The US population has doubled since the 1960s, but the family size has gone down. And we're also living longer. So as more and more of the baby boomers get up into their 70s and 80s and 90s, and the higher proportion of chronic diseases that need support is there, it's going to become very, very challenging, very, very expensive. However, there's also a trend, of course, of people wanting to age in place, to stay at home. So the only way we can reconcile, we can deal with this ongoing tidal wave of seniors is to, and we can't build the facilities fast enough, even if people wanted to stay in the facilities, is to leverage technology. And an important part of leveraging that technology is addressing isolation and loneliness. We can use wearable sensors, we can use machine learning, we can use edge computing. There's so many great things we can do to connect people with healthcare providers. But we also have to connect people with other people. And especially during the pandemic, it's been impossible to go in and seeing your elderly friends and relatives. It's going to continue to be an issue because of distance, even if we solve the pandemic-related concerns of issues. So addressing senior isolation and loneliness, and there's been a lot of research showing that the most caustic thing on health for seniors is isolation and loneliness, more than smoking cigarettes. However, the good news is technology is getting close to the point where we can provide very, very robust interactions. Now, to get to the story I mentioned I was going to tell you, I did some work a decade ago helping vets who were coming back from our wars who had post-traumatic stress. And as part of my diligence to understand what the best products would be to help address their post-traumatic stress, I asked them, how did you stay in touch with your family and friends while you were deployed? To my surprise, many of them said, well, we met inside World of Warcraft. And when I said, why are you meeting your mom inside of World of Warcraft? Were you playing a game with her? And they said, no, we would just go for a walk. And that's because it's hard. You run out of things to talk about when you're having a video call. It's stressful and exhausting, but if you can do something, it's sort of like driving together in a car. You can focus on something else, you can have a conversation, you can do things. And the good news is technology is soon getting us to the point where we can have very robust, multi-user virtual environments that are exciting, engaging, and not weird. Right now, we can use cloud-based real-time rendering to make the graphics fantastic, even on a computer that's 10 years old. You don't have to have a gaming computer. And we're building out the content and the systems to allow us to have multi-user virtual interactions at a distance. That's a way to have an engaging experience. Now, it could be a clinical experience. We could do telehealth, but we can also just do things, have fun. Take your granddaughter shopping in Florence, Italy, using a virtual environment and shopping to buy shoes. It's going to be great to be able to do things in these online virtual environments. Now, we have some work to do. Right now, the avatars look very robotic. They're not very good at the nonverbal communication, but we're getting there. And I think that'll go a long way for addressing isolation, loneliness, and connecting people.
Beautiful. Cindy, I know you think about this all the time too. I'd love to hear you chime in.
Yeah, I mean, I have 2 points. Both of them. Well, the first one is not to disagree with James, but to maybe just disagree a little, James, is that when back to the provider front of this. Yeah. I mean, there's a great book called Compassionomics that talks about the fact that providers, in fact, do not do a good job of treating what I call the softer side of healthcare, right? They're very good at the clinical stuff, but if you say you're lonely to them in the office, it's almost paralyzing. They don't know what to do. You know, it's not a chronic condition that they're used to treating. And social determinants of health, food insecurity, safety, transportation, that stuff isn't that much better. But at least there's community resources that they can point to. And so I'd say that we have to do a lot of educating with our providers about how to handle this. And that's going to start with innovation. There have to be prescriptive solutions for loneliness, and loneliness needs to be treated like a chronic condition. Then the providers will come along. And then with what Walter's saying is, like, I totally agree with everything that you said, but PICS in particular, we serve only vulnerable populations, primarily Medicaid and Medicare Advantage, who have behavioral health diagnosis, and virtual reality and Alexas and even Wi-Fi are not a part of their world. So how do we get them tech like we do on PICS that works on a Samsung 5 when they've never downloaded an app in their life? You know, there's the populations that are really suffering and have been long before COVID don't have means, and they're often ignored by technology innovation. And so I'd say that there's, you know, when we think social isolation and loneliness, particularly in the senior community, which Walter, I would love to talk to you sometime offline about the stigma, because what we find is that people inside our platform that test lonely on the UCLA loneliness scale, chronically lonely, they never use the word lonely to describe themselves. They say sad, they say anxious, they say different things, but it's not lonely or isolated. And so anyway, those comments have no answers. They're just comments, which is that we have to, as we innovate in this space, I think we're going to have to think about the varying degrees of sort of who we're serving and the other healthcare players in the stack, right?
Yeah, absolutely. Absolutely. So I think that really brings us to a question that I'd like you all to think about and answer for us, which is, what can we all do now to and this is, you know, almost starting to get into maybe a call to action for those that are in the audience and listening to us talk. What can we do now to positively impact human connection in this environment, in this, you know, time that we're in right now, and as we start to move forward? Because it is a moving forward that I think we can all expect. It's not a going back. It's not a return to. We need to create a new future. And so what can we do now to start making that impact and continuing that motion forward? And what tools are available, and what can our future generations of innovators bring to the table? And I know that's a kind of packed multi-part question, but let's get into it. This is the time and place, and I know our audience is hungry for that conversation. So let's do it.
Ramona, I'll go ahead.
Do it. Yeah, jump in.
Sure. First, I would like to say that, Cindy, actually, we weren't disagreeing at all. So essentially, there are two disciplines. There's behavioral health, and then, of course, there's traditional medicine. The main goal of Medicare Advantage, if you will, and Medicaid is to treat the whole patient in more of a population health type of framework. And treating the whole patient means that you're not just looking at the patient from a transactional medicine perspective, which is what a lot of historical medicine has been. And as we transition to more of a population health, then we can start treating the whole patient. Now, from a technology perspective, what do we actually do to treat the whole patient? And I'll just use Medicaid Arizona as an example. The state mandated that anybody who sees a primary care physician actually gets screened for behavioral health and social determinant issues every time they speak to a doctor. And once that data gets collected, then that person can be referred to a specialist, and that starts at least an infrastructure to be able to treat the whole patient. But that's not sufficient, not because it's not a good start, but because there just aren't enough providers. Once you start going down that path, they just frankly don't exist. So what the future has to bring for us to be able to create that infrastructure is really to have that digital front door, or that artificial intelligence engagement platform for the patient, to be able to treat the whole patient, to be able to evaluate them, be that conversational interaction, such that it can predict when the patient needs the intervention from somebody, and only when they need it. And then it will also, if it turns out to be something that's non-traditional medicine, if you will, then maybe it is just setting up some type of social group for the patient if they are lonely that they can do over a technology interface, if it's a time that we have now, or if it is something that can be done in person, hopefully, when the pandemic is over.
I think there's a lot that can be done with helping those people who need the most help get to the front of the line. All too often, someone makes that very difficult phone call to try and set up an appointment because they're dealing with depression, they're dealing with addictions, they're dealing with anxiety. And they're said, okay, we can see you, but it'll be 3 months. And we need to have a way to leverage voice analytics, to leverage other information, interfacing with EMRs perhaps, but we need to have ways to help those people who need help right away, get help right away, and to allocate the resources that we do have. And I think technology can help us there. And Cindy, to your point, and I agree with you completely, we must not have technology be a barrier. Now, I think that there is ample ways we can leverage the affordances on our smartphone technology, which have become ubiquitous even with people who are homeless. It's a way to have people be connected, and fantastic applications like you've been developing can be used to both screen, to intervene, to assess, and to connect. So Ramona, you asked, what can people do? Well, I think it depends on what you know how to do. If you're a designer, if you're an engineer, if you're a scientist, if you're a specialist in electrical engineering, there are groups that are developing fantastic solutions to these problems at the academic level, at the early stage startup level. So I think it's just pursue your talents and your passion to identify a problem. There sure are enough problems out there. But I would just say jump in. And even if it's to join a user group to talk about these discussions that are related to your field and how they can be applied, I think there's more than enough need out there. And it could be a career path for those people who are looking for what to work on next.
Great.
Yeah,
Cindy, your
so
thoughts?
yeah, I think that part of what gets missed a lot is that we think about solving for these problems within the confines of what we know to be healthcare delivery, right? And so social determinants is a great example, and loneliness I put squarely into social determinants. Is that when the state of Arizona mandated that you have to get this information every time you interact with a provider, it didn't mandate what to do in the moment when you find out someone needs food or you find out that they're chronically lonely. Instead, it goes into an electronic medical record. It takes 3 or 4 weeks. By the time somebody gets around to contacting that person, it's a complete waste, right? So how do we engage people where they are so that we can get the data when we need it and actually react? One of the things we pride ourselves on is that at PICS, is that when they tell the robot that they have a food insecurity, we will get them a resolution in 24 hours, not 3 weeks, not 5 days. And then that brings me to my next point, which is really about understanding about, there's this term called practicing to your license. Like, you don't want physicians, you don't want nurses doing these kind of interventions. You want to create that peer model of care where I can be somebody who gets on the phone with Ramona and just provides her companionship. And then I'm trained enough that I learn that she hasn't, and this is a true story for one of our members recently, hasn't taken a shower in 2 weeks because her shower seat broke. And so I'm going to make sure she gets it. And so those are the small things that then keep people out of the emergency room, overutilizing. It keeps them from going into such a severe depression that it's difficult to pull them back. And the second part of your question, Ramona, like, what can people do? This is just me. And I realize it's a little flippant, but I mean it. Like, what we do here is I say we need to be the antithesis of healthcare technology, right? We have to think differently. And we have to first and foremost solve a pervasive pain point for the end user, or all of this great stuff that comes with technology, moving data from point A to point B, creating efficiencies. That all goes away if people don't engage. And people only engage if you're really, really solving something for them. And so to me, that's where innovation lies. Like, think going upstream.
Yeah, absolutely. Great thoughts, everyone. And I want to just make a couple of final thoughts to sort of crystallize everything that you said today and shared with us as we sort of start to transition into Q&A. And I see a number of different questions coming into the chat. Cindy, you mentioned peers and having a peer available, and we've talked a lot about compassion, empathy, understanding some of the issues that a patient might be facing that aren't immediately obvious to us when we're engaged in that that patient and provider conversation in our traditional visit. The incredible feeling that we have when we're with someone that we love, that Walter shared with us, when we just take a walk together and do something that's simple and not necessarily prescribed. And what I want to say is that when we are able to not only pair a patient with somebody that is a peer to them, but we're able to train a future generation of caregivers that have that walked in their shoes, that peer background, and empower them as caregivers, then we get a future generation of healthcare workers that's the full package. So those of you that are in the audience that have aspirations to move forward into the future, and you can bring all of that together into your practice, all of these capabilities that we're talking about, the compassion, the empathy, the understanding, the social needs, the loneliness, the isolation, that's really where we start to move forward into new care for our patients that have needs. So I think that that's really something that we can start to think about as we move healthcare forward. Any final thoughts from our panelists before we jump into Q&A?
Well, the interesting thing about all of the discussions about what we can do and should do is that the technology actually exists today for what we should do. And it's just a matter of getting all of the disparate organizations that are involved to actually adopt aggressively. And then you can start learning as you go on. I mean, as an example, figuring out what the true intervention is for every patient, a chatbot experience could understand all that with an AI that's trained appropriately. And then it could actually suggest the right intervention if it is just delivering a shower chair, as Cindy mentioned. Whatever it may be can actually be resolved in a very cost-efficient manner. But the will to do that is where the challenge lies, because today, unfortunately, people don't get paid for it. And ultimately, that's the challenge. And so population health hopefully solves that problem, because then you're paying an organization to keep people healthy. And that's where these things that fall through the cracks get resolved. So that's the future I'm looking forward to.
That's great. Thank you. Let's answer some questions. So first one that we've got here in the chat, thanks Lance for chiming in here, is how do we, this actually really speaks to what you just said, James. How do we transition all the internet resources, the online coherence, classes, telehealth, and how can we make these new expectations become more common post-COVID? And since you were just talking about that, why don't you jump in? And so I think it's, not only that technology exists, but how do we get that motivation? Because that is the issue. I think we're all seeing that and fighting it.
For sure. I mean, the interesting thing, just from a motivational standpoint, is medicine is business. And if your business is not making money, no matter how nice the person is or how well-intentioned they are, there's an end to their ability to do it. So it has to be self-propelling in terms of profitability. So when you start looking at treating the whole patient and using all necessary technologies to be able to do so, you have to first start compensating the people who are involved accordingly. And that is where I think the number one issue is. The federal government has actually done a remarkable job with Medicare Advantage, that it was the first population health initiative in the nation. Population health has been talked about for a very, very long time, but really it was the first one. And Medicaid, although it's not really implemented very well here in Arizona yet, has a promise for population health and treating the whole patient. And if they start just by compensating, I think the rest will get along. So that's on the policy side. In the culture side, there's a whole issue here, because before COVID, doctors are pretty much anti-risk takers. Anything that is associated with risk, they're not going to adopt. And technology is always risk. So it has to be forced upon them. And with COVID, they were all forced to use telemedicine, which quite frankly was a great thing. It's terrible to say COVID had good after effects, but this is one of them. Because now the fear of actually using telemedicine is gone. And we have an opportunity to really implement technology in a broader fashion to be able to solve these huge issues.
I think one thing that needs to be pointed out and kept on our radar is that things are changing. The continents are colliding more than just the, change in reimbursement and getting used to using telemedicine and teleconferencing. Even before the pandemic, there were some major earthquakes going through our healthcare system. And by that, I mean the fact that the consumer electronics companies are jumping into healthcare, that consumers are jumping more into healthcare directly through expanding health and wellness over to clinical care, that companies like Amazon are providing, being healthcare providers directly. Places like Walmart and Walgreens and CVS are becoming more and more healthcare centers. The usual clinic-based method of seeing patients through the existing healthcare infrastructure is dynamically changing. And what's lubricating the whole process is technology. So I think we need to keep in mind is, yes, we need to change public policy. We need to change so many things to adapt the existing healthcare structures and government regulations and FDA review and public policies. But I think we also have to acknowledge that there's a great change going on with from a consumer level of managing healthcare and getting involved. And I think if we can amplify that and map it to what we're doing, I think we're going to see some fantastic changes.
Great thoughts. Anthony has a great question in here, and I'm going to read you guys the question, and I think you can answer it, panelists, in general, the way Anthony has asked it, but you may also want to speak to how it directly impacts your direct work. So Anthony asks us, what is the process or timeline of implementation of new policies or treatments being accepted by insurance companies and various government institutions? That is a big piece of the puzzle too. So thanks for that, Anthony.
I actually sit on the Coalition just to End Social Isolation, and it's a lobby and a group out of Washington, D.C. that deliberately goes into, the Hill and tries to lobby for some of these things. And the answer is it's an eternity. It doesn't matter if you have kind of inertia. And even with the pandemic, we have inertia. It's all of a sudden now people have started to, they've self-experienced things like isolation and loneliness, and there's research to prove. But there was something that James said that I think is really important. You can change policy from, and Walter was hitting on this as well, by one, following the money, and two, creating demand. And so there was a study before COVID that was done by Becker's that in South Texas, where 80 members in the span of 12 months went to the ED 5,139 times, 80 members. And when they went back and interviewed them, and it cost $14 million, and they went back and interviewed them, the number one reason was loneliness. Like, for example, it was Turkey Thursday and you're lonely. And so you're going to go into the ED and get turkey and talk to the very, very nice people that work there. So it's that kind of stuff that will spur policy change faster. It's consumer demand that will spur policy change faster. But the traditional way of going about it, expecting our legislators to legislate for CMS to get on board, et cetera, I won't be doing this by the time that comes around.
Cindy has a very, very good point. The interesting thing though, and I will go ahead and advertise another local company called Equality Health. They have actually taken the full ownership of the patient to a new level with the type of population health that they're trying to implement. Now, there's always challenges, you know, and everyone's had their own experience with population health. But I do believe that the structures that the state and federal governments have put in place, at least in the reimbursements for population health, through these type of structures are helpful. And that gives me hope. Now, the majority of the United States is private payer. And, you know, if you look at Aetna CVS merger, part of the big advertisements of this and why this was supposedly a great thing was that they are going to offer population-based health services in all of the CVSs for the Aetna members. So they could go to the primary care doctors many times. They would help them get their food, their needs, or they help them in their loneliness areas or whatever it may be, to help them stay healthier and stay out of the ED. Exactly as Cindy said, I mean, 40% of the people that show up in the emergency department never should be there. And so how do you keep them out? You keep them out by engaging with them before they go. And so I see we're starting down the right path. I guess I just wanted to balance the foreverness, which is true, totally. Don't wait for policy change because you'll be very old. But we have made great progress, and I think we have the tools in place where we can actually implement something fantastic.
Real quickly, James, I think that Equality Health was one of our other groups that spoke on a panel earlier today. So if there are folks that are listening to this and didn't have a chance to hear all of the sessions, they are recorded, and you'll get to hear a little bit of what Equality Health does and how they think about some of the challenges that healthcare is facing right now, if you get a chance to listen to some of the recorded sessions. So thanks for the shout out to your colleagues. Anything to add, Walter?
Well, I remain optimistic. I certainly agree with all the challenges, but I also think that, you know, I'm seeing every sector rise to the occasion. And yes, I'm not going to wait for changes at the government level. That would take forever. But I do see, for example, some large healthcare networks and one of the largest insurers group investing in developing new solutions to address these problems and promulgating them because of population health reasons. They're not saying we're only going to fund this for our members to use. They're saying we're going to fund this, we're going to study this, and we're going to release this digital health application to the world, because even if someone isn't a member of our network now, they will be later, or they might be later. So there is positive change going on by some of the major players. And again, I think what's lubricating all this are the big advances we have in sensor technology, connecting technology. We have a digital health platform that we can use to do so many powerful things. So I think it's just a matter of leveraging the tools we have and not waiting for policy changes.
Great points. I do believe that takes us to time. Taylor, perhaps you can confirm or deny that we have so many other questions and great comments, and I certainly would love to talk to this group forever and hear our audience's questions, but alas, all good things must come to an end.
Yes, yes. Unfortunately, are out of time, but I want to thank you, Ramona, for facilitating this panel. Thank you to Cindy, James, and Walter for joining us as panelists today. And thank you to all of you for attending this session. We are going to actually offer some random door prizes today. Typically, this event is a full day conference in person where we give out all kinds of goodies and we offer catered lunch. And we didn't get an opportunity to do that today, but we still wanted to support our local food entrepreneurs and provide you all with some nice gifts. So we've randomly selected 3 of you to win some virtual door prizes. So I'm going to announce those winners right now, and we'll be in touch with you via email to facilitate the delivery method. So without further ado, our first winner is Felicity Blackwater. Congratulations, Felicity. You have won a Bake at Home holiday cookie gift set from Hunger Bomb Cookies. Our second winner is Alicia Mendoza. Congratulations, Alicia. You have won a Costa Rican coffee brewer and gourmet beans kit from Pura Vida Grinds. And our final winner is Amina Aiden. You have won half dozen homemade Pop-Tarts from Laurel Bakery. So congratulations to all of our winners. And as I mentioned before, we will contact all of you to facilitate the delivery of those items. But I want to go ahead and one more time thank our panelists and our moderator today for joining us. Thank you all for attending this conference. And if you've been at multiple sessions, thank you so much for supporting us. We are the Health Entrepreneurship Accelerator Lab at Arizona State University. So we serve the university and the community at large to facilitate these kind of health entrepreneurship and health innovation programs. So we hope you all found this event enjoyable, and we thank you so much again for joining us. And if you want to reach out to any of our attendees or our speakers, you feel free to do so. I know we had plenty of questions that we didn't get a chance to answer. And we'll be sending a follow-up email with a survey that we'd like you to complete with your feedback. So keep an eye out for that as well. But without any further comments, I'm gonna go ahead and let you all free. You're free for the weekend, but thank you all so much again for joining us, and we appreciate all of you. Happy holidays.
Thank you.